Move on to our third presentation now from Dr. Bushra Kawaja.
Hello everyone, my name's Bushra Kawaja. I'm a GP in North West London and also a primary care lead for Royal Marsden and Partners Cancer Alliance. It is a great pleasure to be here today to talk about a quality improvement project that I implemented in my practice. It's especially a great pleasure to be here after my friend Ali, and I only found out last night that I'm on after him as the agenda came out quite late. The suit looks great, and we were discussing our outfits last night. So, on to the project. Before I actually go on to the project, I know not everyone in the room is clinical, so I'm just going to give a little bit of background, and that will help just to give a bit of context. So we've heard this word, FIT. The project does center around the FIT test, so I'm just going to spend a couple of minutes explaining what a FIT test is. So the FIT test detects blood in the stool, which may not be visible with the naked eye. This can be a sign of early bowel cancer. And as we know, it is about diagnosing cancers early to increase your chances of successful treatment. A positive FIT is taken as a FIT of 10 micrograms of hemoglobin per stool or more. And why is this? Well, we know that studies have shown that a FIT less than 10 means your patient has a very low chance of colorectal or bowel cancer. So that's put at less than 0.1%. So essentially, it helps to stratify your patients in terms of bowel cancer risk, and it helps to make those decisions about which patients need to be referred for urgent suspected cancer. In my practice, we look at all cancer diagnoses with a case review. This helps us to look at what could have been done better. There was one particular case that really stood out. It was a late-stage cancer diagnosis, and the case review revealed that the patient was given a FIT test, but she never returned it. So we identified a problem. Some patients being given a FIT test just weren't returning it. They were slipping through the net. We needed a safety net. So a little bit sad here. This is my favorite see the signs function, the FIT safety netting function. All my friends hear me talk about it. So see the signs have a very streamlined function for FIT safety netting. It has been added on later than when see the signs was first launched. So I do find as my lead role that some people have missed it. So when the clinician logs on, the toolbar's at the top, you can go straight to the FIT safety netting button, and this adds the patient to a dashboard so they can be followed up later. So why safety net FIT return? And when I refer to safety netting, I'm basically talking about the fact that FIT is looking for cancer and I need my patient to bring that FIT test back, so the process around that. Well, we've already covered one of the reasons. Not all patients return their FIT. Another reason is, well, NICE, the National Institute of Clinical Excellence, they want primary care to safety net their FIT. There are also some cohorts who are less likely to return a FIT test. So these cohorts include male patients, those under 65, those of Asian ethnicity, and also those from the lowest social deprivation quintile. And therefore, having a process around safety netting FIT return aims to tackle inequality. Now onto the project. So, Wood Lane Medical Centre, so my practice, implemented a FIT return safety netting process using See the Signs. When the clinician would give the FIT test to the patient, they would click on the FIT safety netting button, and the patient would be added to the dashboard. The admin team, as part of their daily tasks, would review the dashboard, and at 2 weeks, if the FIT hadn't been returned, the patient would receive a text message, and at 3 weeks, they would receive a follow-up phone call. The admin team would also ensure that all FIT results were actioned. So a positive FIT of 10 or more, they would ensure that an urgent suspected cancer referral had been made. Negative FITs, so FITs less than 10, were also highlighted to the clinician in case any other follow-up was required. So the process was put into place in June 2024. Data was reviewed in retrospect over 3 months between June and August 2024. The information recorded included the number of fit tests requested, the number of positive results, and also the clinical outcomes of the positive results. So the results. During that 3-month period, 40 fit tests were requested. Thanks to our safety netting process, all 40 were returned, basically due to our team badgering the patients until they returned them. 5 of the patients did return a positive fit test of 10 or more. All 5 were referred on for urgent suspected cancer investigations, and 2 colorectal cancers were diagnosed. So in summary, it is essential for primary care to have a fit return safety netting process to prevent missing out on diagnosing bowel cancer early. See the Signs has a streamlined process for the safety netting function. And the patients that benefit the most from fit return safety netting include vulnerable cohorts, such as those of the lowest social deprivation quintile. And therefore, having a fit return safety netting process tackles inequality. Before I take any questions, I would like to thank Molly Callahan, our compliance manager at Wood Lane Medical Centre, who's here in the audience today, who runs the fit safety netting process, and without her the project wouldn't have been possible. And also Sophie Ruiz from the Cancer Alliance, sitting at the back there, for her ongoing support as always, and especially with this project. So thank you very much.
Thank you. Any questions? Microphone over there.
Thank you. Very interesting. And as a practice, I can see that we would really benefit from that. I just wonder, I know busy GPs, we are all trying to be as efficient and keep up, keep ticking everything that we need to. I wonder how many of us forget to tick the fit safety netting button. And in your practice, did you get any fits coming back that weren't on the safety netting function?
That is a very good question. If I think about what we did before we used the See the Signs fit safety netting function, we did have a short period where we trialled sending a PN, adding it to a spreadsheet, and then Molly's nodding her head there, because then the admin team would have to then color code manually, whereas with See the Signs, it's all done for you. I haven't identified a fit that wasn't added, but it is possible that that happened. But we are reducing the steps. We are reducing the chance of that happening. It wasn't automated, no. So that it's still up to the clinician to click on that button. But as I keep saying, it is my favorite See the Signs function. It is just one button, and it's there. When you log on, the toolbar is there.
I'm just going to add briefly to that there is some newer functionality that means it is automated based on coding, which not all practices will have access to yet, but it will be coming.
Excellent.
Any other questions at all?
Just curious if, feedback-wise, when you're proactively calling patients who haven't returned, what general feedback have you had? What challenges you face, other than language?
Of course. If we can get a mic to Molly, because she does the calls.
Molly, raise your hand. She's looking for it.
She's there at the front. So Molly, what happens? Because I don't actually know, because Molly calls the patients.
I think that it's quite a taboo subject, and I think often patients feel that it's not, maybe they don't understand the importance of receiving and returning the fit sample. So I've been educated so that I can also explain that to the patient, and then I think it is also just it being taboo. So just reassuring them, really.
Thanks, Molly.
Yeah.
Time for a couple more questions, if anyone else has any. One at the front here.
Thank you. It sounds brilliant, so thank you. I just wondered, before you implemented the safety netting, what were your fit return rates?
That's a very good question, and Miles did ask me that, and it was too close to the conference to look at that data. So we will have a look. I did look up the evidence around it for general practice in the UK, and 15% don't come back in some studies. I suppose it depends on the area. You know, as I mentioned, there are some cohorts where they're less likely to return it, so I presume that number could be higher, but that's definitely something that we'll be looking at, because it'd be nice to compare. So thanks for that question.
Any final questions? If not, thank you very much, Bushra, and we'll move
Thanks
on
a lot.
to our final presentation.